Hi guys, welcome back. The topic we're gonna study now is hepatorenal syndrome, which is a complication of decompensated cirrhosis. In fact, when it comes to the incidence of the disease per se, 10% of cases of patients who are suffering from advanced cirrhosis. Therefore, most patients will be first having ascites, which will subsequently become converted into refractory ascites. In fact, refractory ascites is one of the important diagnostic criteria for this condition, and the main reason for updating this video is that there are revised criteria that are available. There are new terms also, like earlier we used to read terms like type 1 and type 2 hepatorenal syndrome, but now it has been replaced by newer terms that I'll make you aware of as we progress in the disease. This condition overall will be having a poor prognosis and would be necessitating requirement of orthoptic liver transplantation. Do appreciate the fact that the problem per se is not in the kidney. There's a pre-renal variety of acute kidney injury, understandable. There's a oliguria followed by anuria, understandable. But it is not the kidney that is fault. The problem lies in the liver per se. So what is the pathogenesis of the disease is of paramount importance, because once we know that, we'll be able to treat this condition as well. Though from the MCQ perspective, I want you to remember that albumin and octreotide, or we can use midodrine as well in place of octreotide for management of this condition. How they work and how will they be effective will be told to you subsequently, but I've just verbally highlighted. The question said, what is the treatment for hepatorenal syndrome? So we have to use albumin, upgrade the oncotic pressure, and use vasopressors as well. Because nowadays integrated questions are asked, so they can mix this with pathology. You see, as I said, the problem is not in the kidney. The problem is starting from the liver. So histopathologically speaking, unfortunately, in case the patient expires, we take a kidney of the patient and then we are subjecting it to a histopathological examination. The glomerulus will be perfectly normal, though this what I've said is purely for academic reasons, because we most of the time will be making a diagnosis on clinical grounds, and that clinical criteria does not include liver biopsy. As I said, these patients would be having a functional acute kidney injury. In the exam, he loves to ask about the types of acute kidney injury. We have pre-renal, renal, and the post-renal subtypes. So for the exam perspective, do remember it's the pre-renal subtype. Now we come to the most important question for this topic. Why is it happening? Why is there a development of a renal vasoconstriction? In fact, one of the important reasons for renal vasoconstriction can be understood from the fact that you very well know the baseline data. Prostaglandins are important for maintenance of glomerular filtration rate. In fact, two prostaglandins that I'm writing before you, prostaglandin E2 and prostaglandin I2, these are vasodilatory prostaglandins. The main function of these would be that they help in increasing the renal blood flow. And if you increase the renal blood flow, you will be able to increase the glomerular filtration rate to maintain the perfusion. At the moment, I've written simple function of these vasodilatory prostaglandins that they're gonna help in maintaining the renal perfusion. Now, the bad news is when it comes to hepatorenal syndrome, there is a urinary loss of these vasodilatory prostaglandins. Mark my words there. I said there is a urinary loss of vasodilatory prostaglandins. So if you lose vasodilatory prostaglandins, the manifestation that will occur in the patient will be a predominant renal vasoconstriction. And if there's a renal vasoconstriction, blood supply of the kidney is hampered. So that explains why I was calling it the pre-renal subtype of AKI. There's a second reason behind this as well. So let us assume this to be a cirrhotic damaged liver. Studies have shown that the damaged cirrhotic liver will be producing endothelin 1. And this what it does is it upgrades the endothelial nitric oxide synthase enzyme, which is present in the splanchnic blood vessels. And if you upregulate this particular enzyme, then there will be more synthesis of nitric oxide. So though it is written casually in the books that a cirrhotic liver contributes to more nitric oxide production, the reason behind this would be production of endothelin 1, upgrade of the endothelial nitric oxide synthase system. And once you have more of nitric oxide, then this is going to cause a splanchnic vasodilation. And the bad news with the splanchnic vasodilation is that the kidneys would be compromised, because they would be shunting of blood away from the kidneys. So there is two reasons why I mentioned that this disease will manifest in the patient. First, I said there is a renal vasoconstriction due to urinary loss of prostaglandins. Therefore, initially they tried giving prostaglandins for management of these patients IV, but that did not work. And the second problem that we have encountered is a predominant splanchnic vasodilation. If you are having shunting of blood away from the kidney, the perfusion is down, there would be oliguria and subsequently anuria developing in the patient. So we will now focus on the revised criteria for diagnosis of hepatorenal syndrome. One of the prerequisites would be that the patient would be having refractory ascites. The definition of this I have explained earlier also. I'll repeat once again. You are using spironolactone max dose up to 400 milligrams. You are using furosemide up to 160 milligrams. But in spite of this diuresis that you're trying to introduce, still there is a substantial ascites present in a patient. It can contribute to tense ascites and it can cause even respiratory difficulty. It can even cause a hepatic hydrothorax as well, because the ascitic fluid can move by the fenestrations of the diaphragm into the pleural cavity as well, and therefore breathing difficulty can be seen. Over and above this, the serum creatinine of the patient is showing a progressive rise. If the nourishment level of the patient or the muscle mass of the patient is preserved, then the serum creatinine, which will definitely send the alarm bells ringing, would be a value more than 1.5 milligram per cent and a substantial rise. But the manifestation that you would have seen is lots of times, especially alcoholic patients, they would be having substantial wasting, substantial catabolism in the body. So the muscle mass is anyway reduced. If in a person muscle mass is reduced, creatinine values can actually be turning out to be on the lower side because they're directly related to the muscle mass. So he says alternatively that there should be a rise of serum creatinine by at least 0.3 milligram per cent over the baseline values. I want you to remember that serum creatinine can definitely be affected by muscle mass in extremely emaciated patients, in sarcopenia patients, in cancer patients. Serum creatinine values can be normal, but still kidney malfunction can be occurring primarily because it is corresponding to the muscle mass. So if you're having or documenting a rise of serum creatinine over the baseline in the previous 6 hours, and the urine output of the patient is decreasing, normal you very well know is going to be 1 ml per kg per hour. If it downgrades by 0.5 ml per kg per hour over 6 hours, then that implies that there is a kidney malfunction. So what are you going to do in this patient? You are going to stop all diuretics. Why? Because diuretics when given in excess can contribute to dehydration. Dehydration can contribute to a renal malfunction as well. You have to stop the high dose diuretics which are already being given in this patient for the next 2 days. And for point number 4, ideally they say that you should be putting a center line as well as a Foley's catheter in the patient. Why a center line? Because you're going to start this particular patient on now volume expansion. When I say that I'm going to start the patient on volume expansion, initially or in the previous edition of the same app or in the older books, it used to be written that we give a fluid challenge to the patient. We give 1.5 liters of normal saline. But currently he says that do not give 1.5 liters of normal saline because sometimes that can contribute to even heart failure, because a lot of patients could be having concomitant heart disease as well. So he says rather it is safer to do volume expansion with albumin. Dose you don't need to remember, that would be about 1 gram per kilogram, and the max amount of dose that you can use is about 100 grams. But the logic is that when you're giving albumin, it will contribute to increase in oncotic pressure as well. It will try to reduce the amount of ascites in a patient. You see, ascites is ultimately a third space loss. When I say a loss, ultimately kidney is at a disadvantage because that fluid should be used to actually maintain kidney perfusion, but it is wasted in the peritoneal cavity. So if I get the fluid back into the vascular compartment, there are chances that the kidney perfusion will increase, and if kidney perfusion will increase, urine output will also increase. That is why I said if I put in a Foley's or if I use a condom cath in the patient, then I'll be able to document the rise of the urine output of the person. And why am I putting a center line? Ideally because I would like to measure the CVP as well, because I do not want these patients to have any kind of cardiac compromise. So it's always a good idea to maintain the CVP of this patient. Now, assuming the fact that I have stopped diuretics, I have done a volume expansion, but the urine output is still not improving, that definitely tells me that there would be fundamental problems in the form of prostaglandin loss in the urine or the nitric oxide aspect that I explained to you. But there are more aspects which are to be remembered, because you have to be very sure about the diagnosis of this condition. So obviously you need to do vital monitoring to rule out that there is no shock. Similarly, you need to document the patient is not on any kind of nephrotoxic drugs. Like if a person is having infection, you are using aminoglycosides in high dosages, especially tobramycin, etelmycin, they definitely have to be stopped. So this is a diagnosis of exclusion. The person should be off diuretics. Obviously, the reason why I said why off diuretics, because they contribute to dehydration and underperfusion of the kidney. I also need to demonstrate there are no nephrotoxic drugs. Why? Because they would contribute to the renal variety of renal failure. And similarly, I need to rule out any possibility of, I can do an ultrasound here and I can rule out parenchymal disease, as well as some post-renal causes or obstructive causes can definitely be ruled out by ultrasound as well. When I say no parenchymal disease, it's not only an ultrasound, but I would also like to have some objective evidence as well. So let's look at how do we identify parenchymal disease. You see, whenever parenchymal disease would be present, there would definitely be a proteinuria present. So if I document that the proteinuria of the patient is less than 500 milligram, here I'm writing more than, because if parenchymal, I wrote, English to be deployed here. I said no parenchymal disease as demonstrated by or as indicated by proteinuria more than 500 grams per day. So if it's lesser than this, no issues. If it is higher than this, that means there could be a concomitant parenchymal disease or your diagnosis is wrong. Similarly, you need to demonstrate that there is no evidence of any microhematuria. The cutoff that they have put up for this is at least 50 RBCs or per high power field. This should not be present, because I started the discussion by saying glomerulus is normal. If glomerulus is normal, therefore there should be minimum, because after all, we do have RBCs in urine of a normal individual as well. But if there is a glomerular damage which you are not picking up, then that would be an error of judgment. So this is a diagnosis of exclusion. You need to rule out the parenchymal aspects, and there should be no, the word no coming up a couple of times. Logical 4, 5, 6, 7 can be remembered logically. There should not be hypovolemia demonstrated. There should be no nephrotoxic drugs present in a patient, no parenchymal disease, and no abnormal renal ultrasound should be present. If all of these conditions are satisfied, then we can say that hepatorenal syndrome is occurring in the patient. Now, before I go forward, I just want to see whether you have followed me or not. So listen to this discussion very carefully. You have a patient of chronic liver disease. He has already developed ascites. It could be a refractory ascites, might be associated with tense ascites, respiratory difficulty, and especially when there is a tense ascites, especially when there's a tense ascites, there is an increased incidence of variceal bleeding. So this patient had, let me say, one episode of vomiting of blood at his house, one in the car, and one on reaching your hospital. Now you admitted this guy, his vitals are on the, I would say, unstable side, and therefore you have admitted this guy, maybe put a IV cannula, give fluid resuscitation, maybe asked for arrangement of 2 units of blood as well. But while you are monitoring the input-output chart of the patient, you notice that the urine output is substantially reduced to the level that the patient is gone into anuria. You see, he had this episode couple of hours back, 2 or 3 episodes serially, and after that there's a renal compromise in the patient. So what you did was you, whatever urine sample was available, you decided to check for the urinary sodium, and you found that the urinary sodium values were elevated. In fact, he can just mathematically put values like 40, 50. Usually in the pre-renal variety, urinary sodium is less, but in the acute tubular necrosis, you will always notice the fact that salt will not be absorbed. So here I've said urinary sodium is high or fractional excretion of sodium is elevated. So what I'm trying to say to you here is that this is a case where there is a volume loss from the body. There's a volume depletion contributing to acute tubular necrosis. This is definitely not hepatorenal syndrome. So not every MCQ of chronic liver disease, which is gonna start talking about development of renal compromise, should be blindly answered as hepatorenal. This is volume depletion contributing to acute tubular necrosis in a patient. And to be doubly sure, what I can also do is, though this facility may not be routinely available, in the urine of this patient, I can definitely check for biomarkers also. Like I have talked about biomarkers of tubular damage, especially like neutrophil, gelatinase, associated lipocalcin. So NGL values will definitely be elevated in acute tubular necrosis, but there is no tubular necrosis in hepatorenal syndrome. So therefore, the biomarkers can be normal as well. So mainly you need to understand if there is a refractory ascites patient and his creatinine is showing a substantial rise, but you need to rule out a couple of aspects. Stop the diuretics of this patient, perform a volume expansion, considering that he should not go into heart failure, and then rule out the pre-renal and the obvious pre-renal and the post-renal causes. And if you can eliminate them out, then hepatorenal syndrome is definitely in. So these are the revised criteria as compared to the older ones. And you will notice that in the previous edition I was talking about a fluid challenge being given of 1.5 liters of normal saline, but here I'm talking about mainly albumin to be administered. So albumin is useful not only for diagnosis of this condition but even treatment as well, because it restores the circulating fluid volume. You see, hepatorenal syndrome can be having two subtypes. In the older edition in the app and in the older edition in the books also, they used to write type 1 hepatorenal syndrome, which has a progressive course to the level that over a duration of 1 to 2 weeks, a patient might become anuric and then subsequently even expire as well pending a liver transplantation. But when it comes to type 2 hepatorenal syndrome, it was having, I would say, in comparison with type 1, a relatively better prognosis, because the disease was relatively slowly progressive and the chances of the patient surviving were about 3 to 6 months. That's not a very big time. I'm saying just on a comparison sake. What they have done in the current edition is that instead of writing hepatorenal syndrome type 1, they're writing terms like HRS-AKI, which means fast progression. And then if you read the term HRS-NAKI, that is non-acute kidney injury. Looks a little, I would say very expressive term, HRS-NAKI, but then these are the newer terms which I want you to remember for the same disease as well. So in case they decide to ask questions from the older edition of the textbook, great, but then these new terms you should also be familiar with. It's just simply the fact that the progression of the disease will be relatively slower and the patient is having a dire need of liver transplantation because liver is at fault. However, that will take some time. So let's look at what is the treatment to be done for these patients. The first and the foremost drug that I can use in this patient over and above albumin will be octreotide, or I can be using midodrine as well. Now, what is the role of these octreotide or midodrine molecules per se? Because they are after all vasoconstrictors, and the query from most of the doctors is that, sir, on one hand you are saying this disease is having a renal vasoconstriction and you're giving vasoconstrictors. Well, I want to tell you that these are vasoconstrictors that will be mainly acting on the splanchnic blood vessels. When they ask about the action of octreotide, it is mainly going to be on the splanchnic arteries, and as a result of it, if you constrict the splanchnic arteries, then I can say the venous flow, the portal venous flow will definitely reduce. And if I reduce the magnitude of portal hypertension, then the severity of all these manifestations will also reduce. I want to highlight this fact. What this drug is doing by its vasoconstrictor action is, one, it will act on splanchnic arteries as well as splanchnic veins. If you constrict arteries, the venous blood flow will anyway be reduced and even the veins will be constricted. So what you are neutralizing in this case is the splanchnic vasodilation. By use of octreotide and midodrine, I am not neutralizing the renal vasoconstriction, because that's a protective reflex. Every time kidney suffers, it undergoes a renal vasoconstriction. So I'm not trying to neutralize what the kidney is doing routinely. What I'm trying to neutralize is point number 2 in the pathology, that is splanchnic vasodilation, which was occurring in this patient and was contributing to less blood supply to the kidney. This is the one that is primarily being neutralized in this case. And yes, subsequently this patient will be requiring a orthoptic liver transplantation. I shall now be comparing manifestations of hepatorenal with hepatopulmonary syndrome. So let's look at what's the fundamental problem here, and it is the liver still to blame. So just diagrammatically I have represented a cirrhotic nodular liver, and this will be causing more production of endothelin 1, and the same endothelin 1 will cause overexpression of an enzyme by the name of endothelial nitric oxide synthase. So in the splanchnic blood vessels as well as in the pulmonary bed, I repeat the fact once again, both in the splanchnic blood vessels as well as in the pulmonary bed, the nitric oxide production will increase. Once there is more nitric oxide, there would be dilatation of the pulmonary vessels. So on the first look, it looks like everything should be fine, because you see, if this is alveoli, there's going to be gas diffusing from the alveoli to the red blood cells. But the problem is, if the blood vessels diameter gets increased, a lot of these RBCs might actually be passing through this blood vessel without getting oxygenated. If I just enlarge this diagram, what I'm trying to say is that the oxygen which is present in this alveoli with a normal blood vessel around it the oxygen will be able to diffuse into each of these red blood cells, that is the ones which are closer to the wall of the alveoli, including the one that I'm marking at the moment. This RBC, which is a little away from the cut section of the alveoli, will also get oxygenated properly. But if I dilate this blood vessel due to nitric oxide, then the RBCs that I've shown in color blue, I've shown a couple of them in pink and a couple of them in blue, the ones in blue are the ones which are not getting properly oxygenated. Why this is happening is because they are further away from the basement membrane of the alveoli, so there's a possibility they might actually pass through without getting oxygenated, and therefore the technical term that I'm writing for this one is called as intrapulmonary shunting. You see, when you read congenital heart disease in babies, we read about right to left shunt and right to left shunt. So as a result of it, the thought process of everybody, when we read this word shunting for the first time, is as if blood is going from one chamber of the heart to another. But here I have explained to you the fact that it's not that the blood is moving from one chamber of the heart to another. Inside the lungs, what is simply happening is that if the caliber of the blood vessel increases, the red blood cells which are farther away from the basement membrane might actually not get properly oxygenated, and therefore there would be hypoxia. Another problem would be that due to gravity, you see, if I am sitting at the moment and there are dilated blood vessels in my lungs, then the weight of these blood vessels will keep on adding. So the basal parts of the lung will be affected because of the weight of these blood vessels to the level that they'll crush, right? And because of the crushing impact, I can also say that the breathlessness component will decrease. In contrast, when the same person will lie down flat, then the effect of gravity will become relatively equally distributed over whole of the lung. You see, the way I'm sitting, the lower part of the lung will be affected the maximum. Whereas if I'm lying down, then the effect of gravity will be equally on all the part of the lung. So in these patients, these dilated blood vessels, these heavy blood vessels, they crush one another, especially the lower parts of the lung. So oxygen saturation tends to fall in these patients when they sit. You see, I'm not describing orthopnea. Orthopnea is a condition where you are having breathlessness when the patient is supine, so he will prefer to sit up. But what I am describing in this particular patient is that when this person will sit up, the dilated blood vessels, the weight of these overall, if you consider in the lungs, they'll keep on pressing on the adjacent areas of the lung, and therefore the lowermost part of the lungs will be taking the maximum impact, because of which the oxygen saturation can fall, and therefore intrapulmonary shunting is contributing to a ventilation perfusion mismatch. In spite of the fact that the blood supply is more, still there is a perfusion defect which is occurring in these patients, and the very characteristic manifestation of this condition, platypnea, is what I have highlighted. In fact, in MCQs, instead of writing the word platypnea, he might even write the word orthodeoxia, which simply means that there is a drop in oxygen saturation when the patient will change his position. Now, what will be, in fact, in the exam, he can even ask you regarding the definition of orthodeoxia. So what you want to use is a pulse oximeter in this patient. When you are using a pulse oximeter, you will notice that the SpO2 of this patient will fall by as much as more than 5%. Let me say while he was sitting as compared to when he's supine, or you can do vice versa as well. He could be lying down and then you can make him sit up, just to be sure that you're not having any errors on the part of the pulse oximeter as well. But you will notice that when this person will sit up, then there will be a drop of SpO2 by as much as 5%. In fact, in some multiple choice questions, he might not write SpO2, so you will say PO2 drop by at least 4 millimeters of mercury on sitting up. Overall, in these patients, there will definitely be hypoxia. So PaO2 overall, if you check out the ABG of this patient, will be less than 80, and alveolar arterial gradient would be increased. Normal alveolar gradient is about 5 to 15 millimeters of mercury. In this case, the alveolar arterial gradient would be the higher side, primarily because the lung is getting compromised. The third and the important parameter that is anyway to be present in this condition is presence of decompensated cirrhosis, and this that I've described before you is a triad that is important for diagnosis of hepatopulmonary syndrome. The terms are intrapulmonary shunting. The reason I explained, the blood vessels are dilated, so the RBCs just rush through without getting oxygenated. Platypnea, because of the gravity issues, the lower part of the lungs are more affected in these patients. The weight of the blood vessels would definitely contribute to adjacent parts of the lung getting hampered, or the ventilation perfusion imbalance will overall contribute to a decrease in oxygen saturation. And anyway, this person would be having a decompensated cirrhosis. So if all the three things are satisfied, you would be having hepatitis hepatopulmonary syndrome, or in simple layman terms, it is breathlessness experienced by a patient of decompensated cirrhosis. But this chap is not having a tense ascites, he's not having a hepatic hydrothorax, that I'm saying that the peritoneal cavity fluid via the fenestrations of the diaphragm is coming into the pleural cavity, contributing to breathlessness. This breathlessness is primarily because of the pulmonary vasodilation component. Therefore, before we go forwards, I would also like to use this opportunity to mention regarding important causes of platypnea, and one that I've already explained to you is a patient of atrial myxoma. This tumor will be causing obstruction of the mitral valve. So especially due to gravity, it will obstruct the mitral valve, the inflow into the left atria and subsequent inflow into the left ventricle will be hampered, and therefore there would be pooling of bloods in the pulmonary circuit, which contributes to breathlessness of these patients. Apart from atrial myxoma, even ASD, atrial septal defect, is described. Then the first disease where this was described, platypnea per se, was emphysema. So I want you to remember platypnea, that's going to be when you turn the patient to one side, there's breathlessness, that's going to be with a unilateral massive pleural effusion. Orthopnea mainly with heart failure. But when it comes to platypnea, then the important conditions that I want you to remember would be ARDS, then is respiratory distress syndrome. ARDS again has multiple etiologies, so he can describe that. Then emphysema, ASD, and atrial myxoma. Now we come to how would we work up this patient. So a very interesting investigation is described, and that's one of the important reasons why we're discussing this topic. What we will be doing in this case would be pushing up agitated saline into the heart. Now when we push agitated saline into the heart and we simultaneously do a echocardiography, the bubbles in the agitated saline are something in the size of approximately 25 microns. Whereas the capillaries which are present in the lungs of yours and mine are something in the range of 5 to 8 microns. In fact, I will just put up the figures there, though you don't need to remember them for the actual exam. This is only for understanding purposes. I said this is a pulmonary vessel. The diameter of this is only 5 to 8 microns. This is perfectly normal that I have highlighted. So what I'm saying is, if I push agitated saline containing microbubbles of 25 microns into the heart of somebody via a peripheral vein, and don't worry, it will not cause any air embolism. I'm using agitated saline. The bubble size is 25 micron. So those 25 micron bubbles are not going to be able to cross across these normal capillaries, primarily because they're way big in size, and therefore they will not appear in the left atrium. I repeat the fact once again. I pushed agitated saline via peripheral vein towards the heart. It will go in the right atria, it will go in the right ventricle, it will go in the pulmonary bed. But because the size of these microbubbles is about 25 microns, agitated saline microbubbles, they would not be able to cross these small capillaries. So there will be no bubbles coming into the left atria. But if there is a gross dilatation, let me say the blood vessels now are 3 times dilated. If I push agitated saline via peripheral vein, it will go via the right atria, right ventricle, pulmonary circulation, and those microbubbles of agitated saline will be able to cross these dilated blood vessels because thanks to nitric oxide, and they would be able to come over into the left atria of the patient, and that proves the fact that there is a pulmonary vasodilation, there is a intrapulmonary shunting. This technique that I explained to you is called as bubble contrast echocardiography. The basic concept is the agitated saline microbubbles are not able to come over to the left atria thanks to the size of the pulmonary capillaries. But in these patients where the pulmonary capillaries are dilated, yes, you will be able to see this bubble contrast coming over into the left atria per se. Apart from this, we also have a special radiological technique where we can be using micro aggregate particles which are labeled with technetium 99, and we can be doing a lung scan also. And again, I can say these technetium 99 labeled particles are having a particular size, so they are able to cross these dilated blood vessels, but they're definitely not able to cross the normal blood vessels or the vasculature of the lung. So if we have a pulmonary vasodilation, we have to think of these methods by which, because you see, angiography is good for big blood vessels, right? Why I'm describing this is angiography is good for blood vessels. I'm talking about small vasculature of the lung. As a result of it, we have to use this, I would say, very atypical methods, that is bubble contrast echo and a lung scan, which would be using micro aggregate particles labeled with the technetium 99, and they will cross over these dilated blood vessels, come into the left side of the heart as well. Now, for the management of these patients, supplemental oxygen will always be given, but the definitive management for these patients would be a orthoptic liver transplantation. Again, you can see the problem is not with respect to the lungs per se, but you can see here that the lungs are suffering because of the defective liver. So if I change this defective liver, then the problem of the patient will definitely be taken care of. So these are a couple of aspects which I want you to remember for hepatorenal and hepatopulmonary syndrome. In fact, from the exam perspective, I want to highlight that nitric oxide in excess is the villain for both of these conditions. On a comparative basis, in hepatorenal syndrome, there were two pathologies that I mentioned. One was a substantial renal vasoconstriction. Why? Because there was a urinary loss of prostaglandins, and the prostaglandins that I spoke were mainly prostaglandin E2 and I2. Those are vasodilatory prostaglandins. So you lose vasodilatory, vasoconstriction. And the second aspect I mentioned was nitric oxide contributing to decrease of systemic vascular resistance. But on the right hand side, I described a simple pathology. Nitric oxide will dilate the small capillaries present in the lungs. The RBCs are gonna rush through them without getting oxygenated. As a result of which, there is a decrease in oxygen saturation, which worsens in sitting position. So platypnea has to come up. And if you get this particular concept or this particular table imprinted, then you have understood the basic fundamental problem of this patient. And for the left hand side, as I said, I will obviously be planning a liver transplantation, but pending that, I can be using octreotide. Why a vasoconstrictor is always a question. I have given substantial explanation for it. It's going to affect the splanchnic blood vessels primarily, which are the ones which are contributing to shunting of blood away from the kidney. And if octreotide is not given in options, then you can even use midodrine. The last time I've explained midodrine to you is for management of postural hypotension, but today I'm talking about this drug which will be acting on the splanchnic blood vessels, and the patient will definitely have some time before you can plan an orthoptic liver transplantation for these patients. So these are the details, guys, which I want you to remember for this topic. Keep hammering, keep the focus on, keep on doing questions on a regular basis, and you will definitely break on to the other side.